All right, let's jump right into this explainer. If you're a healthcare professional gearing up for your DHA, DOH, HAD, MOHEP, SMLE, EMRE, or honestly pretty much any major medical licensing exam, you already know exactly what we are tackling today. We're going after the single most frustrating question format on the board, the next best step question. Today we're building a repeatable clinical reasoning method so you never get tripped up by these again.
To show you exactly what we're up against, let's drop right into a high-stakes clinical scenario. Imagine this. A 31-year-old woman comes in with severe lower abdominal pain and vaginal bleeding. Pay really close attention to her vitals here. Her pulse is racing at 126 beats per minute, and her blood pressure is critically low, tanking at 82/54. A quick bedside ultrasound demonstrates free intraperitoneal fluid. So, what is the most appropriate next step? Is it A, repeat the beta-HCG, B, administer methotrexate, C, urgent operative management, D, an outpatient ultrasound, or E, just observe?
Take a mental second right here. Do you have your answer locked in? I really want you to commit to one right now, because it proves just how brilliantly tricky these questions can be, even when the actual diagnosis feels like a total slam dunk.
So here's the major paradigm shift you have to make. Knowing that this is a ruptured ectopic pregnancy and hemorrhagic shock, that's just table stakes. It's not enough. Next best step questions aren't just asking you to name the disease, they are ruthlessly testing your ability to identify the correct clinical priority. They want the immediate, next essential action. It's so easy to pick a medically correct action like giving methotrexate and still fail the question because it's sequentially wrong. Look, methotrexate is for stable patients. For our profoundly unstable patient here, giving methotrexate or ordering outpatient imaging or just watching her, that would literally cause a fatal delay. The only correct answer to save this woman's life right now is urgent operative management. Which brings us to Section 1, the framework, specifically the ExamCure 5-step method.
Let's walk through these 5 steps, because I promise you, having an algorithmic approach like this is your absolute best shield against those incredibly well-crafted distractor options. Step 1, read the final sentence first. Figure out exactly what they're asking. Is it the initial investigation or the definitive treatment? Step 2, assess clinical stability. Look straight at the airway, breathing, circulation, and the vital signs. Is the patient crashing? Step 3, pinpoint the decisive clue. You've got to sift through all that background noise to find the one finding that pivots your management. Step 4, determine the clinical stage. Are we at initial presentation, stabilization, or disposition? And finally, Step 5, select the action that must occur first. You're looking for the option that is strictly necessary right this second, not just something that'd be nice to have.
Okay, let's test this out with our first clinical round. We've got a suspected acute stroke case. A 67-year-old man developed sudden right-sided weakness exactly 45 minutes ago. Now that time frame is a massive clue. His blood pressure is 168/94 and his capillary glucose is totally normal. So what is the most appropriate next step? Start aspirin, urgent non-contrast CT head, a carotid Doppler, IV heparin, or a brain MRI. Apply the framework. The patient is stable, sure, but what's the clinical stage? Go ahead and lock in your choice. All right, the correct immediate action is an urgent non-contrast CT of the head. Let's unpack the why here. Look at that strongest distractor, starting aspirin immediately. Now, aspirin might be absolutely appropriate if this is an ischemic stroke, but you absolutely have to exclude an intracranial hemorrhage first. Giving aspirin to a guy who's actively bleeding into his brain, that's a catastrophic error. And what about the brain MRI? Sure, an MRI gives you incredibly detailed images, but scheduling one delays your urgent stroke assessment and time-sensitive reperfusion therapy. You have to distinguish ischemia from hemorrhage right now, making the CT head the only correct choice. Let's turn up the heat with an anaphylaxis scenario. A 29-year-old woman develops generalized urticaria, wheezing, and a blood pressure plummeting to 78/46 right after getting antibiotics. What is the most important immediate treatment? IV hydrocortisone, IM epinephrine, IV antihistamine, a nebulized bronchodilator, or serum tryptase? Think back to Step 2 of our method, assess clinical stability. This patient has profound cardiovascular compromise. What are you doing first?
This scenario perfectly illustrates the golden rule of prioritizing life-saving measures. The correct answer is intramuscular epinephrine. Now look at those distractors. IV hydrocortisone and antihistamines are absolutely correct medical adjuncts for anaphylaxis, but they are wrong answers here because they take time to kick in. They must never, ever delay the immediate administration of IM epinephrine when you have an unstable patient. And that serum tryptase, it might help confirm the diagnosis later, but it does absolutely nothing to stabilize a crashing patient right now.
Let's drop you into one more high-tension scenario. A 35-year-old man comes in with severe respiratory distress after blunt chest trauma. He's hypotensive, he's tachycardic, he has absent right breath sounds, and his trachea is deviated. What's your next step? Chest radiograph? Immediate right chest decompression? A CT chest? IV antibiotics? Or supplemental oxygen? You should instantly be seeing red flags for obstructive shock here. So what's your very first move?
If you went with immediate right chest decompression, you nailed it.
With a life-threatening clinical diagnosis like a tension pneumothorax, ordering a sophisticated diagnostic test like a chest X-ray or CT scan would literally cause a fatal delay. You simply do not send an unstable, dying patient into the CT scanner while their heart and lungs are actively being crushed. You decompress that chest immediately based entirely on your clinical science. You secure their survival before you ever even think about a scanner.
Moving right along to Section 2. Clinical nuances, where we'll look at avoiding common exam traps.
Here is your ultimate instability checklist. Like we've been saying, stabilization always supersedes non-essential investigations. If your patient has airway compromise, severe respiratory distress, hypoxemia, hypotension, altered mental status, active major bleeding, or a severe arrhythmia, they are fundamentally unstable. You've got to run your ABCDE priority: airway, breathing, circulation, disability, and exposure to immediate life threats before doing anything else.
Now, examiners absolutely love testing whether you can separate the initial investigation from the definitive one. You need to actively contrast these two in your head. A super common trap is giving you the most accurate definitive test as an option. But if a faster preliminary investigation has to happen first, like grabbing a bedside ultrasound for a trauma patient or a non-contrast CT for a stroke, then that definitive test is the wrong answer for the next best step.
And you know what? The exact same logic applies to treatments. Imagine a patient pouring blood from an upper GI bleed who is hypotensive. Yes, the definitive treatment to fix the problem is an endoscopy, but the correct initial next best step? It's getting IV access and starting hemodynamic resuscitation. Unstable patients have to be resuscitated to ensure they're actually alive to make it to that definitive surgical or procedural control.
So the key here is sidestepping these 5 common traps. Let's run through them real quick. Trap 1, choosing the most accurate test prematurely. Trap 2, treating before you've confirmed a crucial exclusion, like bleeding. Trap 3, investigating an unstable patient instead of resuscitating them. Trap 4, jumping to definitive treatment before you've stabilized the patient. And Trap 5, just flat out ignoring the specific wording of the question stem. Whenever you evaluate an option, make it a habit to ask yourself, what has to happen before this option?
All right, let's bring it all home with Section 3, Rapid Clinical Recap, and your final exam checklist.
Here is your final checklist for exam success. Seriously, burn this sequence into your memory. 1. Identify exactly what the question asks. 2. Determine if the patient is stable. 3. Find that one decisive clinical clue. 4. Identify the current stage of care. 5. Ruthlessly eliminate answers that are medically correct but premature. And 6. Choose the safest action that must happen right now. Remember, these exams reward structured reasoning over rote memorization. They want proof that you can sequence clinical decisions safely and reliably.
Ultimately, you've got to train your brain to separate immediate management from definitive care. Practice more exam-focused clinical scenarios and hard elite MCQs with ExamCure. And before you face your next tricky scenario, ask yourself, when the clock is ticking and a patient's vitals are crashing, will you know exactly what to do next?